in the event start. Right. So I wanted to understand that if you were called to an emergency for attending a patient with acute chest pain, how do you actually approach the patient, and what's the kind of help you expect from the lab in such a situation?
Well, Harit, chest pain is decided or is deciphered on the triad of three parameters. The first is a clinical presentation, the second is an ECG, and the third is the biochemical markers, the cardiac enzymes, as we kind of, very routinely call them. So, cardiac enzymes occupy an extremely important role in the entire diagnostic approach to a patient with chest pain. Of course, I'll take each one of them one by one. Clinical, uh, the essential diagnostic criteria in a clinical setting is to identify whether the pain is typical or it's atypical. There are two different settings. Atypical pain is something which is a crushing precordial chest pain, which we've been hearing since times immemorial. If there is typical pain, uh, naturally our index of suspicion to diagnose acute myocardial infarction or to diagnose unstable angina goes up immensely. Uh, if it's the role of as associated things, ECG and biochemical markers becomes more if the pain is atypical. Suppose a diabetic comes with some kind of atypical chest pain. We are not very sure whether this is an MI or this is not an MI. That's where the role of ECG and biochemistry comes in. The second step is deciphering the ECG. ECG is further divided into very typical ECG changes and atypical ECG changes. Typical ECG changes is something like an ST elevation. It's outside the purview of this discussion, but if you have an ST elevation in concordant leads, you know that this is an MI. The problem is many a times the ECG is not very informative, or it's too early or too late to diagnose acute coronary syndromes. And that's where the third level of investigation comes in, which is biochemical markers. So biochemistry, even though it may be an on-site biochemical help, it may not be help through the biochemistry lab, has a very important role in us diagnosing and treating myocardial infarction.
Right. So there is this concept of door to balloon time. What is that, sir? Could you just explain it for the behalf of people who have joined us?
Yeah, yeah. See, earlier it used to be called door to needle time. Basically, in our parlance, we say time is myocardium. That's a broad kind of management approach. The earlier you open up a blocked coronary artery in a patient with a myocardial infarction, the better his myocardial preservation is likely to be, the more myocardium you'll be salvaging, and therefore the net effect of a myocardial infarction can be reduced by opening up the artery as quickly as possible. Earlier, when thrombolysis was the mainstay of management, uh, that time it used to be addressed as door to needle time. That means how much time when a patient reaches the door of an emergency to the time that you start the uh, thrombolytic infusion. Now, because many hospitals have kind of changed their approach to managing myocardial infarction, and coronary angioplasty has become the preferred line of treatment wherever there is a cath lab setting. So the timing has been changed from door to needle time to door to balloon time. That is the time which is the time at which a patient reaches the door of the emergency to the time that you do the first balloon dilatation before when you are opening up the coronary artery. So in a good center, the door to balloon time should be less than 1 hour. That's usually the target. But this could vary depending on lot of demographic uh, kind of indications and lot of social parameters, because in India we see a very heterogeneous group of patients. We see some patients who are completely covered by some insurance or the other. Naturally, their decision-making process is faster because you've excluded the finance out of the whole equation. Patients who pay out of pocket, it's a sudden bolt from the blue, so they take their own time to decide. And therefore, door to balloon time as a scientific indicator in India can be very, very, diverse because we do not have a homogeneous system of management. In a place like the UK, where NHS, or many European countries where public health systems cover everything, this is a more robust, indication.
Okay. So the catchword which you told me was that time is myocardium, and so the earlier it is done, the better it is, right, sir?
That's right. Yeah, that's right.
Okay. And
So can I ask a question here, Professor
Yeah,
Hemant?
please. Yeah.
You, when the symptoms are very typical, so it is very easy that you may or may not wait for the lab results to come in. You can start your, the procedures that
Process.
have to be started. But if the thing is very atypical, would you
Yeah.
be waiting for the cardiac enzyme reports to come in, or would you still wheel the patient and start your treatment?
That's a very good question. It will probably vary from one patient to the other. Also, with the availability of point of care lab testing equipment, it takes us only, in our center, it takes us only 20 minutes to get the lab report, to get the first biochemistry report, which is hugely helpful. So by the time a patient, by the time you establish the indication, the protocol in our center is that the moment you establish an IV line, the first sample goes for we call it cardiac triage, but it's essentially the same. We do three parameters: CPKMB, troponin, quantitative troponin, and NT-proBNP, which is basically a marker of heart failure. So the first part of the first answer to your question is that it actually doesn't take that much time. 20 minutes is about the time when we are able to wheel in a patient into the cath lab, and we get the report by the time we take punctures in the cath lab and all that. So that's the first part of your question. The second part is, suppose the troponin is negative and the pain is atypical. Would I still subject him to an angiography or not? It entirely depends. There are a lot of social influencing factors here. There are some patients who will come and they will say, Doctor, I want a definite answer. I don't want to take chances. A lot of urban educated Indians are actually the kind who would say, Nahi, nahi, Doctor Sahab, we know what an angiography entails, and therefore please go ahead and clarify our doubt. We don't want to take any chances. These are usually patients, I practice in Gurgaon, huge IT sector presence. These are usually patients who have seen some calamity happening in their office. Some
Yes.
colleague has
Or
died
in the
suddenly,
family.
or the family. So these are patients who want very definite answers. There are others who would say, Nahi, Doctor Sahab, let's wait. You be more sure whether this is an MI or not. So in these patients, in these cases, we admit them, we observe them for 6-8 hours, we do a ECG, repeat set of cardiac enzymes after 6 hours, repeat an ECG after 2 hours and 6 hours. That's our protocol, that repeat ECG at 2 hours and 6 hours. Now, if all three sets are negative, the ECG is normal, and the two sets of cardiac enzymes are negative, we subject them to a stress test, stress echo, or a stress thallium, or a treadmill test. And usually they turn out to be negative because our index of suspicion has gone down. So that's how we approach. A lot of things in management is actually now patient driven and patient guided. So guidelines would suggest that you should do an angiography. In fact, the guidelines are very clear that even if you suspect a coronary syndrome, you must do an angiography. But I don't think that applies across the spectrum of Indian patients. We deal with a very heterogeneous group. That's a point I'm trying to make.
That's true.
Your cornerstone of diagnosis, let's take from the biochemical point of view, the cornerstone of diagnosis is hs-Troponin, correct, sir?
Yes.
Okay, just for the benefit of the younger students, because we've got the whole PG group also attending
Yeah.
this session, because I want them to see biochemistry from the clinician's eye and not from the biochemist's eye. hs-Troponin and troponin are ideally the same molecule. It's just that the sensitivity of the test is different. For any test to be qualified as a hs-Troponin, at the lowest limit of detection, the maximum CV allowed is 10%. Now, what do we mean by that? At the lowest level that you can detect it, you should have a plus or minus 10% deviation. Only when a test clears that are we going to call it hs-Troponin. Now, I want all of you to be a bit chary about this statement, because you have a lot of people who come down and give you tests and say that our lower limit of detection is as good as the hs-Troponin test, so why don't you use this? The importance is the 10% CV. And why the 10% CV is important is that any subtle changes, let's say from 20 to 25, the number changes. You need to be sure that this change is actually from the myocardium and not a random error because of the test protocol itself. So whenever you're doing an hs-Troponin, whenever you're trying to incorporate hs-Troponin into your vocabulary, please ensure that it meets this criteria before accepting the test. I hope I'm quite clear with the youngsters. Now, sir, hs-Troponin becomes your cornerstone of management. You touched upon this, that if the hs-Troponin is raised, yes, very good, the patient is gone inside. How do you approach a equivocal, that is like 25 is the normal cutoff in the normal population. So if you get a value of say 25 or 35, which is not high enough, but not normal enough, and the patients are going to bug your brains on that. And if, God forbid, something happens and they say the value was high, why didn't you react? Or if a person comes normal, because we know many a times that the initial presentation hs-Troponin can be normal. So how would you then manage a patient based on this report?
That's actually a very good question, Harit. See, there are two variables which we need to factor in at this time. One is how far after the index, how much time after the index pain has the patient come. Usually, troponins start going up at around 4 to 6 hours after the onset of the event. They continue to peak for about 12 to 24 hours, and thereafter they start reducing. They eventually become, normal in about 5 to 7 days, provided the renal function is all right. So the first thing, suppose a patient has come within 2 hours of index chest pain, and you find a troponin which is borderline. Now, this is a troponin which I know is likely to go up over the next, say, 4 or 6 hours, and the pain is typical. If the pain is typical, if the background is there, a 65-year-old male smoker comes to me within 2 hours of chest pain, and I find his troponin is 27. Now, this is something that is likely to be positive, because the entire clinical background is that of an acute coronary event. Now, let's look at the reverse. There is a patient who says कि मेरे को 3 दिन पहले I had chest pain, and after that I've been essentially all right. He comes now, there are some borderline ECG changes, and you do a troponin which is 25. Now, this is a patient which we know, by the third day or the second day, his troponin should have peaked. So if it has not gone up, you know that this is likely to be, insignificant.
Unstable angina or
or a non-specific rise. The second thing, which is actually understated, when I was doing my DM, we were never taught this emphasis of kidney failure, renal failure affecting the levels of troponin. The impact is huge. In fact, it's so high that I have stopped relying on troponin as the only marker in patients with renal failure, unless the troponin levels are in thousands. Very often you get a renal failure patient whose troponin would be 80, 90. All renal failure patients, because of their left ventricular hypertrophy, have some ECG changes. Because of hyperkalemia, they have some ECG changes. So it's very difficult to decide whether he's having an acute coronary event in these patients or not. Also, we must understand that subjecting a kidney failure patient to an angiography carries the risk of contrast nephropathy and things like that. So, these are delicate subsets. So these are patients where we need to be slightly more careful in making a judgment call, maybe rely more on CKMB than on troponin. And the second thing is, these are patients in which a rising trend is more important than just a unitary value of troponin.
So speaking about kidney failure and CKD patients, as Dr. Saab, you'll be aware that there are two types of tests available for troponins, troponin I and troponin T.
That's
And
right.
there has been a lot of debate on whether troponin T is better or troponin I is better, or both are same as the guidelines seem to suggest. So have you had any experience in this field?
Yes, see, when we started, the practice, when troponins just came in, I trained in the non-troponin era most of the time. Then troponins came, and they came with a huge bag. And Roche was the first company that came out with a bedside, qualitative troponin test, troponin T test. And then companies started coming in with troponin I. The thing is that I don't know what markers do you have in your lab. Most of the places where I've worked, troponin I has been the quantitative marker.
I is
So
what everybody uses. I
yes,
is what
so
everybody uses.
As of now, I think only one platform is giving trop T, the rest are all giving trop I.
Yes, so our experience is more with troponin I than with troponin T. The quantitative test I'm talking about, not the
Yes.
qualitative test. So quantitative test, troponin I is what is more widely available, and this is the test which actually troubles us with renal failure patients. So it is actually quite difficult deciphering the troponin with a single value of troponin in a renal failure patient whose chest pain is not very typical. If you remember the initial part of my discussion, I said that acute coronary syndromes the diagnosis is based on 3 parameters. If the ECG is typical or the pain is typical, biochemistry fades into background because we know what we are dealing with. The problem is in these atypical syndromes, whether the ECG changes are atypical or the pain is atypical or both are atypical. And it constitutes a huge percentage. It is at least about 50% of patients who come to emergency come with atypical syndromes, which are slightly more difficult. So they need some astuteness in approach.
In fact, in the labs, this is a problem we face very often because we do not know if the patient has CKD or not, unless
Yes.
it's
Yes,
come from
yes.
the nephrology department.
Yes.
So at our end, it's tough for us to know the clinical picture of the patient.
Yes.
But the recent immunoassay platforms that are giving trop-T, they are very clearly stating now that their trop-T is as good or as equivocal as trop-I in CKD patients as of now. Of course, it remains to be seen, how good or how bad it is. But
Yes,
that's what
yes.
the companies are claiming.
Yeah, yeah.
So if
Maybe
there is a change,
yeah,
sorry.
please go ahead. Please go ahead. No,
I
please
say,
go
so
ahead.
if there is a change in the platform, the immunoassay platform in a lab, so it's now become our duty, to explain to the cardiologist, because first we shifted them from trop-I to high sensitivity trop-I. Now, if we are telling them you change from trop-I to trop-T, we are told what is happening. We can't be changing so much.
Yes, so that's where coffee with cardiologists helps.
Yes.
That's where
Thank you.
Hopefully,
Thanks
yes.
thanks to get this information from that side. Yeah, that the question on myoglobin is definitely on, and I'll be touching upon that. I got a comment on myoglobin, so I'll be talking about it. But sir, you touched upon a point about the point of care testing device. So my first thing is the troponin strips that we get. How reliable do you find it, or do you
Well,
ever look at it?
the second question is more important. We don't, I don't go into the technical performance of the troponin I bedside test. But having said that, I can tell you that very often we send these samples as a repeat sample after 2 hours or after 6 hours to the lab, and we are not often stumped on this. But then I must also tell you that the group that I work for is known for cardiac sciences essentially. I mean, it's now called Narayana Health, but it was earlier Narayana Vidyalaya, as you're all aware. So we have very strict protocols which are followed all across our 31 hospitals. So we have a STEMI protocol, we have a non-STEMI protocol, which are of course decided by consensus by, and you will understand, like in all fields, all Western guidelines are not implementable in an Indian subset. That too
Okay.
in an Indian private sector subset. So we need, as a group, we have our own guidelines, and I mean, I'm not often stumped about bedside
The
testing
strip
in the sense
test.
that the strip test. They are fairly accurate. Of course, I believe that they must be doing some calibration, and eventually our biochemistry head must be coming down to check it up and all that, because
No, no,
he
no.
needs to.
So we're confusing two things. I'm so very sorry to interject on this.
Hmm,
You're talking about the point of care testing device. That's my second part
yes,
of the question.
yeah,
Is there something more cruder than the point of care testing device where there was that just like you do the malaria test, right?
strip test.
Strip test. So
Ah, that, I mean, that is, see, I in if you're talking of a, that's what we call as a qualitative test,
okay, correct.
Yes.
where it's just
Yes
a
or no?
yes no answer.
Yeah, correct. That's what I'm talking.
Though many companies like to label it as a semi qualitative test. They
Semi-qual.
say, yeah, they say that if it's a darker color, it is more positive than a, or if it appears earlier. I don't know how much of this have you dealt with about 15 years ago or 20 years ago when these tests came in. Actually, the company people would come and say, sir, जितनी जल्दी सेकंड लाइन आ जाती है उतना ज्यादा पॉजिटिव है, जितनी ज्यादा डार्क सेकंड लाइन आती है उतना ज्यादा पॉजिटिव है. But I don't believe that. The timing mentioned is 20 minutes, and we should wait for 20 minutes before we see it. My problem with the strip test is that it will probably miss uh, some subclinical or some smaller myocardial infarctions, because it is just not high enough to turn the test positive. So while I'm okay with diagnosing an MI if the test is clearly positive, the problem is if it's negative, I have a feeling that it might miss a few.
Okay,
So
so
that
if
so
it is
the
positive, it is positive. It is negative, it can still be positive. So
yes,
that's the take
yes,
home.
yes.
Would you recommend this strip test in smaller hospitals and smaller setups in clinics which doesn't have access?
Well, in India, this
Everything
is a
goes.
highly unregulated segment, and
Right.
there are chemists who would give you a strip test. अच्छा chest pain हो रहा है, ये ले लो, blood दे दो.
No,
So we are talking of a highly unregulated thing, but of course it's all right. It adds to some information for sure. It certainly gives us some information, and I have nothing against getting information. Suppose the test is positive, it forces a person to act fast. My worry is if he's actually having a unstable angina and the test is negative, are we giving him a false sense of security, and therefore
okay.
losing that important period in between?
I think
Exactly,
this is an important word that we need to share to all our youngsters who would be faced with these situations when it comes that the hospital says we can't afford these tests and this is an option. You need to rub it into the management first. I don't think the clinicians may be that much a problem, but the management, you need to rub it into them that if a test is positive, it is positive. It is negative, it can still be positive. So before adopting the test, this criteria should be well known to us and we should be able to teach. As I said, the clinicians don't need to be taught, the management needs to be taught. Ma'am, you were
Yeah,
saying
and
something.
I'll just make one more point here. I think we all need to understand the timeline of expected positivity of these tests. That's very, very important. My worry is that we've all worked in smaller setups. The moment a person comes with chest pain, you don't even ask what's the duration of chest pain. You just order a troponin. Now, the point is that it's not expected to be abnormal. Even in a frank MI, it won't be abnormal till about 4 hours, 4 to 6 hours have lapsed. So you are giving a very false sense of security to these people. A lot of people ask me, Doctor, which blood test should I do if I have chest pain? So I often tell them that, the best thing to do is to take the nearest ambulance and come to a hospital.
So can I just put up a few, I mean, because what you're saying right now is hitting the fundamentals of what I have understood. I mean, the knowledge which was passed on to me and which I passed down to my generations is something like this. A person coming with a chest pain initially get the markers done. Okay, if the markers are positive, definitely act upon it. If the markers are negative, don't rule out, wait for the peak time and repeat the second time. But
That's right.
at
That's
the
right.
time of presentation, a test has to be done because if it is high, you don't know when actually the event had occurred. So this is my teaching, sir. Does that contradict what you're saying, or is it?
No. Except that the second part, if the test is negative, see, most of us are trained in a government setup where price and cost has not been an issue.
Okay.
The problem is, if suppose, let me now turn this question around to you, and if you had the flexibility of doing only one test, one strip is what you have, when would you like to use that strip? Would you like to use it immediately, or would you like to use it at an appropriate time?
You made your point.
See,
You made your point
so
loud and
so
clear.
Make your point.
yes,
And as you said, Dr. Sir, because we are dealing with a very diverse population,
yes,
half the times you may not even get the right time that the person is telling us.
yes,
For them, it could be anything since kal ke raat ke khane ke baad se, ya, something
yes,
vague, equally vague like that.
yes. So it's uh, what I'm only trying to say is that, for sake of caution, don't ignore a first negative report which you may have done too early or too prematurely.
That's a very good point. So now coming to the second point that you were made, and that is something which I want to, why are you this point of care testing device? Okay, I know that Narayan Hridayalaya has got a point of care testing device. Why do you favor the point of care testing device over the lab's report?
Only because of the time. I mean, only because it gives us a far faster report, far earlier report. The point of care testing could be in the lab. It could be anywhere. The thing is that we get the report very quickly. That's my I have see, as an individual and as a professional, I have no preferences from where I get the report, as long as I get them fast, and as long as I can rely on them and find them accurate.
Yeah, yes,
So
sir. So
coming to this, sir, like we in the lab follow a very stringent quality control procedures.
Yeah.
We are very particular about, our internal quality, our external quality. We make sure that we are doing EQUAS programs so that we even compare our results with worldwide reports. How confident would you be about the POCT reports, about the quality, the controls that are set up? Because typically it is a non-lab personnel who's handling the POCT in the emergency.
Yeah, I that's very interesting. It's a different perception than what a clinician has. I told you, fortunately, I work in a setup where cardiac sciences in particular is given a lot of importance. So, and my experience so far has not been bad. Let me put it this way. But eventually, whether point of care testing machines should be in the lab or should be in the emergency, and whether they should be subjected to quality care, and the people who deal with it should be taught to be quality conscious. Of course, we should all have our own quality parameters, and we should all have our own kind of quality testing and tat times and things like that. But this is my experience, that we are not I'm not particularly, what should I say? Uh, I find them fairly accurate. Let me put it this way. So I haven't been let down by this. I haven't been let down by this, and it is a part of the hospital management. I'm aware. My wife happens to be a pathologist, and I'm aware
Okay.
that there are some hospitals who would scrounge on money for putting point of care test equipment in the emergency, and there would be some kind of a tussle. But in our setup, a point of care testing is a given. It's given to the emergency, and we use it all the time. Even in the middle of the night, typically I get a call saying that there's a patient of chest pain. By the time I reach the hospital, actually the point of care testing report is available.
Actually, that is the basic aim of a point of care, that it
Yes,
gives you bedside reports within
yes,
15-20 minutes.
15-20
And
minutes.
I've
hopefully
asked
the
this.
new platforms, I mean, there are some of them which have come in with the stat facility where they even say that 9 to 10 minutes they will give the report.
Give the
So
report.
I hope we will be able to give lab reports even faster very
No,
soon.
Yes,
ma'am. Let me interject on this. The more we cut down on the runtime, okay, we have to be very skeptical about accepting those results because of the number of false positive rulings that start happening with it. We should be very sure. My personal experiences with the D100 for HbA1c assay, they cut down the runtime from 6 minutes to 1.5 to no, from 1.5 minutes to about 30 seconds. The number of false peaks we get in the reports is significant. So when somebody is giving us a lower TAT, let's not go gang-ho with the lower TAT because that's going to get us into a problem. That's my take onto it.
No, but we need to do a proper verification for that before we
Yes.
get it out.
This is not for you and me. This is for
Yeah.
all the other youngsters who are there in the group. I need them to put a caution. Now, there's another interesting question which I had asked Sir a couple of days ago. And I asked Sir again, I know what the answer is. And afterwards, I have to discuss certain critical points with all of you. Sir, what is your general perception of getting a troponin from the lab? How long does it take?
It
From
takes
the
about
lab, not from the POCT, from the lab.
I know that, I got your question. It depends a bit on the time of the day, but we usually get it in about 2 hours time, 2 to 4 hours time. That's the rough turnaround time.
I was expecting this answer, and this is something which I want to share with all the biochemists in the group. And sir, for you also, there's hardly any self-respecting biochemists, and all of us, I believe, are self-respecting biochemists who don't push out a troponin result within 30-35 minutes.
Okay.
From the time I get the sample to the lab, to the time I dispatch the report, any self-respecting biochemist will do it within 35 minutes. 20 minutes on the analyzer, your POCT time of 20 minutes, and the same time on the analyzer, 20 minutes stays. Okay. And we push the reports fast because the moment we get a troponin, like all the tentacles are open, and that's exactly what we do. That's one of our biggest claim to fame, that we support the clinician in making his decision and managing the patient. But this statement, which you said 2 hours, is perfectly right. And believe me, even in ICU samples, the time taken is about 3.5 hours. Okay, I've had a numerous amount of fights in my previous hospital regarding the tax turnaround times. Fortunately for me, the good part about it is all the activities of a sample is time-stamped. When the test was ordered, when the sample was collected, when the sample was discharged, when the sample was received, when the result was processed, everything is time-stamped. I could get out all these timestamps. Anybody ask you IT, they will give you all the timestamps. See where the delay is occurring. Okay. And it's up to us to actually quantify those numbers, show the management, and get them to reduce that window, because that's when Sir will also feel that he gets a report within 20-25 minutes. What Sir says is a perfect end user perception. And we sitting in the lab have our lab tag monitoring, and we say we are doing a damn good job in 20-30 minutes, but we are not meeting each other. And the reason is there is a lot of transit delay, which nobody quantifies, nobody accounts, and it stays in the dark zone. I have done my timestamps. I have worked with the management. I have managed to improve clinician satisfaction on the lab report. Our success story is, this is a very aggressive statement I'm making to all the biochemists in the platform. Please excuse me for making it. Our success story is the day Sir says, I don't need a POCT device, the lab gives me the report. The day we say that, that's our success story. You agree with that, sir?
Thanks very much, Harit. Yes.
So then CKMB, I have heard a lot of clinicians tell me it's a waste. And personally, I know everybody is tuned to troponin, everybody is tuned to hs-Troponin, and CKMB is just going waste. Apart from that one inclusion criteria of CKD, do you think this test should be in our vocabulary or no?
Of course, it should be now. Of course, it should. It has to be. This is uh, probably maybe it's a generational gap, and the point where when we trained, when troponins were not even there, and there was something called a fractional CPK calculation, where you would calculate under the curve the entire CPK and see how much of fraction of CPKMB constituted that CPK, and therefore derived your information about a myocardial infarction. Certainly, all our guidelines say that CPK-MB is a great test to quantify the amount of myocardium that is damaged.
Better than
So,
troponins.
I'm not sure if there's a head-to-head comparison because it will essentially come in your domain and not mine. But troponin is a great test. CPK-MB is a great test to quantify myocardial infarction. Most of us fortunately don't need to choose. You're now, your question is heading towards in a direction where you're asking me to choose one from the other.
No,
So
looking to Indian scenario and patient pocket,
uh-huh.
if CKMB is not adding a value, do you need to dent the patient's pocket? I'm looking from that angle. Each of these tests are complementary to each other. They have their own roles. CKMB can protect a re-infarct, which your troponins cannot.
Cannot correct.
We buy
Correct,
that.
absolutely.
But now looking at the denting in the pocket of the patient, because everybody looks at troponin, nobody looks at CKMB.
Well, I do. I can tell you, I do, and I do it very critically and very analytically. So I certainly have a look. Also, because we have a 3-test point of care machine, it is automatically a part of the entire
Okay.
spectrum. We do not have a single point of care machine, but frankly, I haven't yet applied my mind that if I was to be given a choice of whether I should do troponin or a CKMB, what would I choose? Would I choose a CKMB or a troponin? I agree that most of us have started defining defining acute coronary syndromes from the point of CKMB. When I say most of us, I don't say I'm not talking only about us. Even cardiology societies have started defining unstable coronary syndromes as troponin positive and troponin negative. So in that sense, troponin has kind of taken the pole position in biochemical testing for acute coronary syndromes. But I personally feel, and the number of CKD patients, even borderline CKD, creatinine of 1.4, 1.5, having elevated troponin or borderline troponin, makes me feel that CKMB has its own position in kind of, diagnosing acute myocardial infarction. If the only thing is, if there was a single test to be sent to the biochemistry lab as a follow-up test, you do a 3-point point of care testing, 3-marker point of care testing, and and it's all normal. Now you want to repeat it. You want to do a 6-hour repeat. Probably that's a place where I would be happy with just a single troponin. I may not go in for a CKMB, provided by that time I already know that his kidney function is normal. So in that situation, I may be happy with just a single test. But when a patient comes right in the beginning, I'm quite happy. In fact, I've been pushing my people that for acute coronary syndromes, because very often you miss a pulmonary embolism in this test, so you should also include a D dimer as a part of point of care testing. We are deviating slightly from acute MI, but the first test, to my opinion, should be as wide as possible, because that's the point where I don't know his renal status, where I don't have his initial biochemical profile. Suppose a patient has come with chest pain, his troponin is 25, and I subject him to an coronary angiogram. I find the angiogram is normal, but his creatinine was 2. So I've actually done him harm by not doing a CKMB.
That's true.
So clinical medicine is a bit it's a bit varied. And don't underestimate the presence of CKD in our society. We are the diabetic capital of the country. CKD, borderline CKD in the elderly is extremely common.
So I know we are running short of your time. Our time is very long. We are running short. First, can we request you for a part two innings because there are still a lot of questions not yet discussed. But
Yeah,
there were two questions which came from the audience, and I
Can I
wanted,
just put in one question on, since we were on CKMB?
yeah.
yeah,
Uh, Dr. Saab, I don't know if you're aware that we are doing CKMB activity and we are doing CKMB mass in the lab,
yeah.
wherein the mass is a more recent CKMB test which is done on the immunoassay platform, and
Mhm.
supposedly it is less prone to interferences and more
That's right. Yeah. I'm
sensitive.
I'm aware of this a bit.
So
Yeah.
yeah, so are you in your setup doing CKMB mass?
I will have to check up. I'm not sure what's done in the biochemistry department. I will have to check up whether we are doing CKMB mass. I would presume that our biochemistry department is kind of,
Would be doing that.
what
Should be
would be
doing
doing
that.
that. But I would, frankly, I need to ask the biochemistry head about this.
And
So
how
the
much
peer,
emphasis do you lay on the relative index that would be calculated with the CKMB and the CK? Would
Uh,
you
we we
look
used
into
to
that also?
we used to pay a lot of attention to this. Certainly, as I told you, the relative index. I've forgotten what it was called. It was called relative index, is it? The
Relative
total.
index,
Yeah,
which is the
and in
CKMB
fact,
mass upon total
yes,
CK
and
into
I'm
100.
sure you would remember the era when you would actually make a graph and calculate the area
Yes.
under the graph and calculate it that way. So in the days gone by, we would put a lot of emphasis on it, but not anymore,
Mm.
because those were conditions where, in fact, I clearly remember a time in acute MI you would not give a patient any intramuscular injection because you thought that CKMB would get altered, and you would take a quick IV sample and send it for CKMB estimation. But I think now testing has become much more specific, and now we don't place so much
Mm.
of importance on
Much.
this. I don't, frankly, I don't look at the CPK unless there is an associated cardiac complication like a statin-induced myopathy and things like that, where we look at the total CK. Otherwise, we look only at the CPKMB. For an acute MI situation, we only look at the CPKMB.
so last two quick questions taken from the audience because this was pinned to me right in the beginning and I said I'll catch it up later. Role of myoglobin and then the other more exotic markers, ischemia, modified albumin, heart binding, fatty albumin. We talk a lot about it in the biochemistry literature, but in the hospitals, I've never seen anybody do this test. So your
I just
words on these
complete the
two.
list.
Yes. So first is myoglobin. Frankly speaking, I am not sure why myoglobin went out of preference for a cardiologist. Maybe uh, there was not enough money to be made on its testing or whatever was the reason. But myoglobin does not has. We all know that myoglobin is the first uh, marker to start rising. So in that sense, if I remember correctly, I think it goes up in 2 hours or so.
Yes.
Myoglobin
Earlier than
starts
that,
rising.
30,
By
35
one,
minutes.
by
30.
1 hour it starts rising.
It starts rising. So myoglobin is perhaps the earliest test um, to test positive, and it is a very good test to kind of the sensitivity wise, it's a very good test.
Very good.
Specificity wise, I understand that it's not that great because lots of uh, clinical events could elevate myoglobin, including some extreme form of exercise and things like that. So if a person was to have a myocardial infarction in a gym, you can't swear by the myoglobin levels. Having said that, so sensitivity wise, it's okay. Specificity wise, it's not that great. But I'm not sure why it is not relied upon at all. We have no. I've never ordered a myoglobin. Of course, I've ordered myoglobin tests for other things like statin-induced myopathy and patients with myoglobinuria and all that. But I've never ordered a myoglobin for an acute MI situation.
The other
So
Actually, Dr. Saab, it's because as you said, the specificity is the problem for
yeah,
it.
yeah.
that and when you have a troponin vis-a-vis a myoglobin, and then
Yes.
financial constraints are also
Constraints.
there.
Yeah.
And since a lot of
Similarly,
packages,
since we are talking about myoglobin having gone out of flavor, similarly, when we were younger students, we were also told that both AST and ALT also go up with a
or
myocardial infarction,
LDH,
That's
or
history.
LDH.
That's
That's
history.
history now, isn't it?
History.
We
History.
don't
yes.
History.
we don't
History.
even see LFT report in
I
a
go horse telling my MBBS students not to utter LDH.
LDH.
Or
Yes,
Biochemistry books
AST.
for the undergraduate says LDH, and I go horse telling them LDH is
Yes.
yes,
history.
yeah.
So what about the other markers? The other,
I'm not sure. I don't think, are they clinically available?
is it a
This
question of availability or is it questions of requirement? It's you need it, so we don't, you don't need it, so we don't do it, we don't do it, so you
well,
don't need it.
for that somebody has to come and make me aware that these tests are available, and
You would be
that's a.
interested. You would be interested.
I would be
So
interested.
more
See,
copies.
I would be interested in any test which gives me early diagnosis of myocardial ischemia, which I can rely upon. So for that, I need you to tell me that, okay, as a professional, not as a company representative. See, what has happened now in contemporary practice is that most of the information that comes to you it's a very skewed way of getting information. Professionals don't talk to each other. It's
Yes.
there is an intermediary who's clearly got a vested interest in the whole game, and he comes and starts educating you about some tests which is recently, and most of these are usually post launch availability, post launch information, so he's already decided that he's going to introduce in the market. So that's not the way we should work. I think we need to work more cohesively. We need to have more coffees together, and we need to understand that these are the tests on the horizon. This is the advantage of each test, and this is how we. So, is there a clinical utility? And after we after we cross that barrier, then we come to the next part, which is it going to be an affordable test?
So do you have time for the last question? Please look at the
Uh,
watch.
yes, 8:51. Yes, I can take one more.
Okay. The last question is, this is pertaining to the reperfusion injuries and evaluation of reperfusion. From what I understand in my little bit wisdom is that when you do an angio and there's something called a TEMI-3 flow, if you ensure that the flow is coming smooth after that, then you don't really bother about evaluating reperfusion. But when do you look for reperfusion, especially in the thrombolysis cases, and what are the criteria that you evaluate reperfusion?
Yes, it's actually a very interesting question. Now, reperfusion injury, essentially, you must understand what reperfusion injury is. Reperfusion is that there is a group of myocardial cells which has been ischemic. When you establish flow, so when they're ischemic, they are all storing up their potassium, because the essential contractility mechanism of a cell is potassium based, sodium potassium exchange. That's where the ion channels come in. So what has happened in a myocardium is, which is ischemic, is that it stored all its potassium. So it doesn't exchange its potassium with sodium. So therefore, no contraction happens. The moment you reperfuse, two things happen. One is a lot of stored potassium gets released into the circulation, and that is the cause of all the clinical manifestations of reperfusion, which is bradycardia, hypotension. All this happens because potassium is suddenly released into the circulation. And the second is lot of necrotic enzymes, enzymes which represent necrotic myocardium. They are released into the circulation. So you have a sudden surge in troponin, you have a sudden surge in CPK. By and large, we have stopped measuring. Reperfusion injury has been studied. We have established that there is reperfusion injury always, and we have stopped because it has very little prognostic information. So we have stopped looking at it. You get my point? I mean, it is like saying that have you studied the benefit of oxygen in myocardial infarction? Of course, we've studied, and it's kind of gone and accepted as a foregone conclusion, and therefore we don't study it anymore. But if you were in a scientific setup where somebody is doing a combined, say, PhD thesis under you and under a cardiologist, all this would carry meaning.
Academic, it's more of an academic interest.
That's right. That's right. So we see the clinical effects of reperfusion all the while in the cath lab. The moment you open an artery, and reperfusion is a good sign. Always remember that if a patient gets hypotension, bradycardia, reperfusion, arrhythmias after opening the artery, it's a good sign. It means that there is live myocardium which you are reperfusing.
Okay.
If there is no effect, you've reperfused a dead myocardium, essentially.
Oh, that's a very interesting way of looking at it.
Yes. It's not an interesting way. I mean, it's a fact. It's a fact. So people who have reperfusion problems, reperfusion arrhythmias, reperfusion, we know in our heart that it's troubling us in the cath lab, but it's actually a good sign. He's going to recover. And
So
there are some drugs
one
which...
line.
Yeah, you can.
One
Last question.
extra question.
Last question.
Just one line question.
Yeah.
So as far as the algorithms that are being followed today, they talk of 0-1, 0-2, or even 0-3 algorithms. What are you following in your lab, and what is the one that is generally followed in our country? Because it's a little confusing for us.
What is this regarding? I mean, I'm sure what is zero. I'm not sure what 0-1, 0-2 pertains to.
The language which we have been thrashed around from
I was trying to
pharma
concise
side,
it to save time.
maybe the pharma time and all. They use the 4th International Convention of definition of MI, where they say that hs-Troponin has got a 1 hour rule in, 1 hour rule out, 2 hour rule out, 3 hour rule out, and there should be multiple.
No, we don't.
So that's what,
Yeah, we don't. You asked me this question earlier, but I don't think I need to read up a little more on this. We don't follow it.
Because the guidelines, international
If
AHA, the
Vidyalaya is not following it, is not relevant. As simple as that.
No, we are not.
It's not relevant in our scenario.
Yes.
Okay.
Yes.
So thank you very much for sparing your time, especially in the juncture of this. This is just the first coffee we've had with sir. I think all of you need to go back and have the same coffee with your cardiologist. A lot of things can be made, and I'll have to apply my college connections to pull sir back for another meeting sometime. But it was really wonderful talking to you, sir.
Thank you very much. Thank you, Harit.
Thank you
been a
so much
pleasure
for coming and increasing our knowledge. It has been a real pleasure talking to you.
It's changing my perspective tomorrow when I go to the lab and I look at the cardiac markers. Now, the one take-home message is, before you release that troponin, please check the creatinine also.
Yes.
Please check the creatinine. Very true. And how much time it has taken for the result to reach the cardiologist.
Yes.
That's our job.
Yes.
Most hospitals now have an online app. We have a very, very robust online app. So we get the report the moment your lab testing is over. And we get if your notifications are on, we get a notification. So we are very prompt. There's no wastage of time in that sense. But because the sample has to go from one place to the other, the travel time and how physically the sample reaching the lab, that's what probably delays the whole thing. But thank you very much, Dr. Anjali. It's been a pleasure. And thank you.
Pleasure, sir.
There's a series of messages coming in the chat that they're all so much impressed with you, sir. I can't believe it.
Thank you very much. Thank you.
Thank you.
Very kind of you.
Have a nice movie.
Look forward to another coffee session with you.
And my personal apologies to ma'am on this issue.
Yeah, thank you very much. Thank you, Harit. Bye.